Rheumatoid arthritis, acute flare, mild to moderate pain. You use NSAIDs like aspirin, diclofenac is more used than celecoxib. Severe, you can use steroids also if unresponsive to NSAIDs. Involvement 1 to 2 joints is intra-articular triamcinolone and more than 2 joints oral prednisolone. Long-term management, disease-modifying anti-rheumatic drugs, DMARDs, disease-modifying anti-rheumatic drugs. First is conventional DMARDs, biological DMARDs, and JAK inhibitors. Conventional DMARDs. You have methotrexate, hydroxychloroquine, sulfasalazine, leflunomide, cyclosporin, azathioprine, mycophenolate mofetil, cyclophosphamide. Then these are the conventional DMARDs. Then biological DMARDs are TNF alpha inhibitors, interleukin 1 inhibitors, interleukin 6 inhibitors, abatacept, CD20 inhibitors. JAK inhibitors are tofacitinib, baricitinib, upadacitinib. It causes immunosuppression, increased risk of infection, and not to be combined. Treatment methotrexate anchor drug of choice for new diagnosis. Anti-inflammatory effect within 2 to 4 weeks. So, treatment methotrexate anchor drug of choice for new diagnosis of rheumatoid arthritis. Anti-inflammatory effect is seen in 2 to 4 weeks. Inadequate response after 3 to 6 weeks. Then add hydrochloroquine plus sulfasalazine or abatacept or biological DMARDs in inadequate response like JAK inhibitors or other biological DMARDs. Conventional DMARDs, methotrexate. It inhibits DHFR, so decreases THF, which inhibits purine synthesis and lymphocyte toxicity. Increased adenosine, anti-inflammatory response, and hepatic fibrosis. Increased adenosine. Side effects, hepatotoxicity plus liver cirrhosis. So monitoring is done by doing ALT, AST every 3 to 6 months. Nephrotoxicity causes crystalluria and it also causes bone marrow suppression. DHFR is dihydrofolate reductase and THF is tetrahydrofolate. Hydroxychloroquine. Mechanism of action. It inhibits lymphocyte proliferation and it stabilizes lysosomes. Uses mild monotherapy, moderate, severe, then it is an add-on. Side effect, bull's eye retinopathy or maculopathy. Max dose should be less than or equal to 5 mg per kg per day. So for example, if it is a 50 kg individual, then 250 milligram per day. Ophthalmological examination once yearly should be done in hydroxychloroquine use as it causes bullseye retinopathy or maculopathy. Sulfasalazine. Metabolism of action in gut. It becomes 5-aminosalicylic acid and sulfonamide. 5-aminosalicylic acid and sulfonamide, two metabolites. So out of that, thiamine or salicylic acid is not absorbed, and it is used in ulcerative colitis. On the other hand, sulfonamide, it inhibits lymphocyte proliferation. Monotherapy, it is used in mild rheumatoid arthritis, and add-on, it is used in moderate to severe rheumatoid arthritis. Biological DMARDs. TNF alpha inhibitors. Drugs are infliximab, adalimumab, which is used intravenous, and infliximab, adalimumab, certolizumab, etanercept, golimumab. These TNF alpha inhibitors are biological DMARDs and can be used subcutaneously. Uses: mnemonic alpha inhibitors prevent rheumatoid arthritis is a mnemonic. A for ankylosing spondylitis, then inflammatory bowel disease, psoriatic arthritis, plaque psoriasis, rheumatoid arthritis. TNF alpha inhibitors are used in these diseases. Side effect: GIT ulcer, and hence can cause perforation. It increases risk of infection. It increases risk of secondary skin cancers. Contraindication: hepatitis B, reactivation risk is there. Congestive heart failure. Interleukin 6 inhibitors, tocilizumab and serlilumab, uses rheumatoid arthritis, cytokine storm in COVID-19. Interleukin 1 inhibitor, anakinra, least effective and least preferred biological. CD20 inhibitors, rituximab, anti-cancer drugs, abatacept, inhibits CD80-86, inhibits T cell activation. Belatacept, related to abatacept, uses graft versus host disease. Janus kinase inhibitors. Mechanism of action: it inhibits functions of cytokines. Drug: baricitinib, used in rheumatoid arthritis. Upadacitinib, used in rheumatoid arthritis, psoriatic arthritis, atopic dermatitis, and these are all Janus kinase or JAK inhibitors, which inhibits functions of cytokines. Ruxolitinib is used in GVHD and myelofibrosis, polycythemia vera, unresponsive to hydroxyurea. Abroticinib, used in atopic dermatitis. Tofacitinib, used in psoriatic arthritis, ulcerative colitis, juvenile idiopathic arthritis, ankylosing spondylitis, and rheumatoid arthritis. We will continue with anti-aggregants and hematopoietic agents in the next video.